مرحبا دكتور بتول.
مرحبا.
اهلا مرحبا دكتور بتول.
دكتور شلونك؟
هلا شلونك؟ شلون الاحوال؟
سعيده.
الله يسلمك، نحن اسعد. شكرا جزيلا، ويعني شكرا على القبول بهذه المحاضره. ان شاء الله I expect it to be very interesting.
ان شاء الله اخوي، ان شاء الله.
ان شاء الله. اوكي.
مرحبا. شلونكم؟
اهلا مرحبا دكتور.
هلا دكتور.
اهلا وسهلا يا مرحبا.
هلا دكتوره بتول، شلونك؟
هلا وعيني، فرصه سعيده. شلونك انتي؟
شكرا، تسلمين، وانا الاسعد.
اهلا وسهلا.
لحظه بس لحظه. شلون احوالك دكتوره ميديا؟
الحمد لله، ان شاء الله انتم بخير همينه.
والله تمام دكتور احمد الرباعي، اعتقد ويانا راح يكون بلحظات. مرحبا دكتور احمد.
اهلا 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 دكتور.
مرحبا دكتور.
مرحبا دكتور.
بالضبط، عطلت علينا. اهلا دكتوره بتول.
هلا ومرحبا دكتور.
اهلا دكتوره ميديا، اهلا وسهلا.
اهلا دكتور، مرحبا، شلونكم؟
اهلا وسهلا.
ان شاء الله بخير.
الله يخليك. شلونها ميلبورن؟
والله الحمد لله كله زينه، كوفيد فري.
كونجراتيوليشن.
ترهيتوا اخيرا، ترهيتوا
اخيرا نطلع برا وما نلبس الكمامه. نقدر نتنفس.
احنا ان شاء الله البرزنتيشن شنو رايكم؟ 15 minutes is it enough؟ لو اكثر تحتاجون دكتوره بتول دكتور ميديا.
اعتقد اني مالتي راح تكون 12 to 15 minutes.
اوكي.
دكتور تريد انه انت تسويها شير من يمك؟
هو احنا بس نقدر من هسه نسوي. منو راح يبدي اول شيء؟ دكتوره ميديا لو دكتوره بتول اول شيء؟
عيني كيفكم، اني ما يهمني.
عندنا بعد دكتور سلوان ايضا بالانتظار، دكتور سلوان الصالحي ايضا موجود. واعتقد احنا دكتور كان الترتيب انه البرزنتيشن من 15 الى 20 دقيقه.
اوكي.
بحيث يكون عندنا فد ساعه ماكسيموم، وبعدين فد 20 دقيقه كيو ان اي تصير شغله خفيفه، يعني ما بيها اثقال على الحضور.
عفوا دكتور، البارحه نزلت لكم الايميل لان البيع قالوا اذا ممكن الليست اوف اتنديز، يعني النيم والكلينيك، حتى اذا يريدون يتصلون معاهم يعني للبروشز او السامبلز فيكون عندهم. فممكن بس يمكن ان يعني ناكد على هذا الموضوع من الاتنديز. ما اعتقد راح يكون عندهم مانع.
لا ابدا، ما المفروض يكون عندهم مانع. يعني يمكن through the lecture I can write down their names. او حتى بعدين نزود بليست راح يكون مبين على الشاشه بالنسبه لي انا.
I think this will be يعني good enough for the future. يعني each webinar عندنا list of attendees.
اي صح.
يكون
اكيد
نتواصل وياه زين.
اكيد 100%. اوكي، اذا اول بريزنتر راح يكون دكتوره ميديا ودكتوره بتول.
هو الليست اللي دزولنا اياها كان دكتور سلوان يبدي اول واحد.
اول شيء. اوكي. اذا احنا هسه بالثمانية يمكن ننتظر فدش كم دقيقه، لانه مرات شيء بعدهم الظاهر، فننتظر. Okay, we're recording from now on. Welcome to everyone. I'm really excited for this presentation. Myself have not been in any gynecologic presentation for the last 25 years. So I hope you put up with my basic questions. And I would perhaps present the first presenter so we can start with some housekeeping. Perhaps each presentation will go for 15-20 minutes. Participants would feel free to write their questions in the chat, and we will ask the presenter and all of them in a one lump sum. Our first presenter is Dr. Salwan Al-Salehi. Dr. Salwan is one of the senior clinician and gynecologist. He graduated from Baghdad University in 1992, and he obtained his FRANZ-COG degree as a specialist in gynecology and obstetrics in 2008. And he had paramount and significant experience in urogynecology field as he finished his subspecialty 2011. He is currently in an eminent position as the head of the pelvic floor unit at the Royal Women's Hospital in Parkville, Melbourne, since 2016 until present. He's a member of IUGA, UGSA, and AUGS. He is, as well, on top of that, a certified robotic surgeon. He's been doing that as his specialty. In addition, he consults from multiple private areas, inclusive but not limited to Royal Women's Hospital in Parkville, and perhaps in Upworth and St. Vincent Hospital. We're very proud and delighted to hear from you, Dr. Salwan, about your experience as an update in urogynecology. Please proceed ahead.
Thank you so much, and really thank you to Dr. Ahmed and everyone's actually to invite me to talk in this forum. I'll proceed straight into, and very grateful for the kind introduction, of course, and I feel blessed to be actually to be presenting among the other colleagues that some of them actually I knew for the last many years. I won't say how many. The next I'll go through the presentations. I'm just going to start by saying, look, pelvic floor dysfunctions are very common conditions, very understudied, certainly very much understudied in our side of the world, very underappreciated in everywhere in the world, and it's just a constant reminder that actually that things need actually to be disclosed to the doctor and to the GPs, as well as actually as the specialists to say that actually that I have problems with my bladder, my bowel, as well as my prolapse. Some of those slides I will go through them very quickly, just because in the interest of time. But the prevalence of actually of having to have an operation about incontinence and or prolapse considered to be 1 in 5 in Western society, especially in Australia. That's based on the national systemic study looking at what's the prevalence of having to have anything to do with pelvic floor surgeries. It constitutes a big chunk of the operations done in the States every year, close to about 200,000 operations done in regards to pelvic floor surgery, as well as pelvic floor dysfunction surgeries. The laparoscopic versus the vaginal approach to the pelvic floor surgeries have been varied depending on the conditions of the and the environments as well, and the political aspects favored the abdominal and the laparoscopic surgery over the last number of years. I'll start with the prolapse. The prolapse can be staged at stages from 0 to 4, and that's based on the POPQ stages, which is established in 2009, 2010. It's the types of prolapse to make it as kind of as simple as possible is either the front compartment, which is related to the bladder, the back compartment related to the bowel, or the apical compartment, which is related to the uterus and or the vault in cases with hysterectomy. The women's usually present either due to the direct physical symptoms or it is related to the associated organs or referred symptoms. Therefore, majority of times in my experience, if they don't know they have the prolapse, not because they don't have the symptoms, because they don't know that the symptoms related. This is, I apologize for the severe display of the prolapse, but in these cases, and even in case that I just presented, sometimes women say, actually, I don't think I have symptoms, but then when you explore what are the symptoms related to, they will say, yes, yeah, that's funny, you should say that. So the bladder functions, the bowel functions are really closely associated with the presentation. As well as that, there is the referred symptoms like lower backache, abnormal bleedings, pelvic pain, not very commonly, but it can be associated with it as well. Forget about all the symptoms to some extent for 1 second and concentrate on the quality of life. The majority of times, the quality of life is the one to be considered for women with pelvic floor dysfunctions, because majority of times actually limit their activity. It is a bit of a vicious cycle when it comes to the pelvic floor dysfunctions and women's quality of life. So The symptoms happens. It puts the women in a situations that they don't want to do anything, because if they do exercise, they will feel more symptoms. If they do exercise, they will have more incontinence. That leads, in majority of cases, in deteriorations in their psyche and psychological existence. That will lead into a possibility of weight gain, and that usually results in worsenings of symptoms. So it's a vicious cycle that get to be interrupted effectively by having an attention to the symptom, as well as solving the problem. There are a number of methods to start with. There are sometimes a lot of women actually thinks that if I have something to do with the pelvic floor issues, then must be surgery needed to be done. It's not really the surgery. There are a lot of things that we start with, and that may or may not lead to surgery depending on the presentation. The loss of weight, the being physically active, again, we're very conscious about, expressing to women actually you need to lose weight in order to make things better, but things are connected to other things. While someone would advocate losing weight, but to lose weight, you need to be physically active. To be physically active, you would end up being incontinent, and that brings it back to the same problem. The problems, the use of pessaries, for example, goes back to the Hippocrates. It's been many hundreds of years actually in the attempts of science actually to overcome the problems of the prolapse. So it's not a new problems. It's problems actually is it hasn't been disclosed enough to be on everyday topics. The pessaries are number of pessaries available, for example, as a supportive methods for the prolapse. Those usually are very useful for older women with medical conditions, for those who are pregnant or wanting to be pregnant in the future, and those who are their circumstances doesn't agree with them to undergo surgery, and may need actually to have some form of supportive measures until that happens. There are a number of them. There's a lot of manufacturers. Some of them useful, others are very useless. The ones with the arrows are the main ones that actually I use on a daily basis and for the last number of years. They fit in it's difficult for them to, for women to appreciate how do they fit, and they don't know if it's going to fit on the side or in the middle. I usually draw a diagram for them to say actually exactly this is how it fits, in order for them to appreciate if it actually becomes uncomfortable for any reason. There are a number of improvisations or developments in the field of pessaries, but they are few and far in between when it comes actually to usability. Surgical treatments, I will go quickly through surgical treatments for prolapse. It started many decades ago by the use of plication. That plications for the fascial plication, whether the prevesical fascial plications or the Kelly plications, which is very old way of actually doing the support. Recently, we did study, and it's actually still ongoing with a randomized study regarding the use of the rectovaginal fascia to connect it into the apical support in order to actually support the posterior vaginal wall, and it's really useful. Uterine conservations, it has been always postulated that if you have a prolapse, to have a hysterectomy. Hysterectomy is not a prolapse procedure at all. That hysterectomy doesn't get rid of the prolapse, does not support anything, and the apex is thought to be responsible between 50 to 60% of the presentation of the prolapse. So if you attend to the anterior and the posterior vaginal wall without attending to the apex, you'll end up missing 60% of the support. So there are a number of methods to support the apex as well as the anterior and posterior vaginal wall. This is type of the mesh reinforcements that established back in 2006, and it's ended in 2018. 2017 doesn't exist anymore. That was very useful procedure that unfortunately has been discontinued because of the bad publicity. The apical procedure or the comprehensive procedure, which is sacrocolpexy, luckily still exists, and that's done robotically or laparoscopically. That is one of the only procedures that correct the anterior, the posterior, and the apical compartment at the same time, and it's considered to be the gold standard procedure for anterior and apical prolapse. It can be done robotically or laparoscopically. It's with the use of polypropylene mesh that attached to the front and the back wall of the vagina, and then in turns the leg of the Y shape attached into the anterior longitudinal ligament at the sacrum promontory. You can use the same principle into the uterus, provided that the uterus is free of disease, free of abnormal bleeding, normal size, and the patients herself actually would want to keep it. That's a method that we have endorsed and refined in our unit over the last 7 or 8 years. And we did a study of the first 87 patients, was done between me and another senior specialist, that after 5 years, we have 93% success rate and less than 2% repeated surgery. In cases where the uterus is large, you can actually have a partial hysterectomy as well as sacrocolpopexy. And that is, again, can be done robotically. There are a number of robots actually coming up now, because the original one from Da Vinci in the States and has been controlling to some extent actually and dominating the market for the last from 2006 to 2016. It's reasonably good machine, the Da Vinci, and that's the latest one, which is called the Da Vinci Xi. It's still, in my opinion, it's a bit too bulky and cumbersome in some stages. I had the opportunity to test a new type of robots called Versius. It comes from Cambridge Medical Research System, and the guy who co-invented that is a very good friend and colleague of mine. It's fantastic new developments. There are different legs or arms to the robots that you don't have to use all of them, and they're not attached to the table. As well as that, it's actually a joystick control. Very nimble, very small, and fantastic usability. I usually say the difference between the robotics and the keyhole surgery is the difference between that phone and the iPhone. It's only more refined. You can do other things, but the essential part of the procedure is still intact. There are other old procedures like the Lefort procedure or colpoclysis or the obliteration procedure. That goes back to the 1800s. We still use them very efficiently. I'll just move very quickly because there's only 4 or 5 minutes left to the urinary incontinence. Again, the urinary incontinence is very, very common issues, and it goes without saying that it affects women's quality of life in all aspects dramatically, whether they're interrelationships, whether their confidence in going out or participating in any social events. There are essentially 3 types of urinary incontinence: the urge incontinence, stress incontinence, and mixed incontinence. It costs the budgets of the health funds by up to $42 billion a year in Australia back in 2010, and I can only imagine that increased since then. The majority of that cost goes into the absorbent and the supportive measures that are actually being placed, not to solve the problem, but just to put a damper on the problem, unfortunately. Just moving quickly, and this is available for the AIMA participants actually can have a look at it in a slower fashion. But again, the lifestyle changes, physiotherapy, the use of medication is a very good starting point. The treatment of recurrent urinary tract infections in women is a very essential part of the management and would be very much underserviced if not being paid attention to during the consultation. And postmenopausal women are really in greater chance of developing recurrent urinary tract infection. And there are a number of factors that need to be considered, whether this is physical, meaning that they have prolapse and they don't empty their bladder well, or is related to having a low estrogen parts. There is a product called Hyaluronic, which is the use of hyaluronic acid, which is an essential amino acid that can plug the linings of the bladder linings, and that's a very good treatment for the interstitial cystitis as well as recurrent urinary tract infection. I won't bore you with the use of medications for the overactive bladder, but one of the developments over the last number of years is the use of Botox, for example. Botox has been magical in majority of cases. It has an efficacy between 78 to 85%. The longevity of the use of the Botox can be varied between 6 to 24 months. It depends on the condition as well as how the body process the Botox quickly or not. 2.5% of people may develop antibodies against it. Sacral nerve modulation is very interesting prospects into the refractory and very difficult to treat bladder overactivity. It's pacemaker predominantly. It's the same as the pacemaker. Its interstem is actually produces the pacemaker for the heart and uses the pacemaker for the bowel control as well as for the bladder. It's by introducing an electrode, which is called tined lead, close to the sacral nerve S3, S4, and gets stimulated, and that usually shows between 50 to 60% improvement in the first week. It's a very useful procedure, especially when there is a combinations of bladder overactivity and voiding dysfunction. My cohort of patients, actually very young ones as well, and they use it and they really know how to have a better quality of life as a result of that. The developments in that, because it's a lithium battery, you can't have MRI, and there is an MRI compatible lithium batteries coming up in the coming year or two. And as well as that, there is a rechargeable lithium battery as well, which prolongs the life of the battery. Just quickly, there is a number of modalities available around us, which is like the Nautilus electromagnetic chair, the laser. No tangible evidence to support them use or their mechanism of use. Last but not least, with the stress incontinence, there are a number of surgeries. Birch-Colpo suspension used to be the gold standard procedure from 1965 all the way to 1999, replaced by the sling as a gold standard procedure. With the bad publicity of the mesh, even though the sling is not the same as the vaginal mesh, the use of the slings has dropped dramatically by 50 to 60% worldwide. And we are going back to the beginning, which is the Birch-Colpo suspensions. Other solutions like the bulking agents using Bulkimed or the pubovaginal slings is another factor. I'm just going to mention that I was involved with the Victoria Health, the Commission, Health Commissioner in Safe Care Victoria, sorry. Those names intermingle with each other normally. So they wanted to see how many of the centers in Victoria can be useful in treating women with mesh. So we established the certain steps towards identifying those women, providing services, and try to help them. Our unit is actually one of the leading units in Australia to provide those services, because there are both myself and Dr. Marcus Carey, who's the previous head of unit. We both specializes in treating mesh complications. However, I wanted to highlight one study which is actually done through the NHS with over 90,000 patients, and estimations actually to what is the estimated incidence of mesh complications for women undergone mesh surgery for incontinence and or prolapse, and estimated to be after 9 years 3.3%. I'm done. Thank you. Sorry, it took 19 minutes.
Thank you.
Sorry? Should I stop sharing? You're on mute.
We can't hear you, Dr. Mohanad. You're mute.
Dr. Mohanad, you're on mute.
Yes, all right. I'm all good now. So thank you very much, Dr. Salwan. Very good presentation. Waiting for some questions to come from others. Perhaps I'll start asking my first question to you. As you know, nowadays in abdominal surgery, especially when we think about complicated open or laparoscopic approaches, we always think about doing some fixations prophylactically to avoid an internal hernia, for example, a twisting of a right colon around a pedicle, for example. I was fascinated in the portion of your presentation that you mentioned some partial hysterectomy with a simultaneous sacrocolpopexy. Could you please comment on that in a way of, do you think doing it prophylactically would reduce the risk of future prolapse?
There's no place for prophylactic management for apical suspension because it's associated with complications, and you have to prove that there is a need for it, whether this need is actually exemplified by the method of examinations and findings a tangible apical prolapse, or the patients actually have symptomatic apical prolapse. There is no place in my experience for prophylactic fixation.
Sure, thanks. I would ask another question, if I may, in terms of hysterectomies. Do you think, as a senior clinician, the rate of hysterectomies has reduced for the last 7 to 10 years, knowing that there are other alternatives, for example, to deal with dysfunctional uterine bleedings, some radiological intervention to block some vessels, etc., uterine ablation? Do you see the number of hysterectomies are getting less?
Absolutely. The direct effect of the Marina, for example, have reduced the number of hysterectomies dramatically over the last 20 years. On top of that, the emergence of the uterine sparing or uterine conserving prolapse procedures have seemed to be very popular. And I must say, over the last probably about 5 or 6 years, they start to constitute about more than 40% of my pelvic prolapse surgeries. And that's, if you compare it to about 10 years ago, that was less than 2 to 3%. More and more women don't want to have hysterectomy, and for the right reasons. And more there is a reality that actually that hysterectomy doesn't solve major problems, and without having to have clinical reasons for hysterectomies, you really don't need to. So overall, there are multifactorial reasons for the hysterectomies rate reducing, and some of it medical, some of it surgical, and the development of new methods to spare the uterus and use it as a lever.
Fantastic. The other question is robot versus advanced laparoscopy. You know, in advanced laparoscopy nowadays, we're using even a 90 degrees cameras. And I remember last year, before the COVID, we went to South Korea and they showed us a 270 degrees telescope that can go all the way behind the liver, for example, where you can do a very refined liver resection next to the IVC. Why do you think robot is perhaps a gold compared to a silver laparoscopy? Do you think that is fair, or
I don't think it's gold at all. I think sometimes it's actually being painted by gold, but underneath it's it's a fake metal. No, in all honesty, the benefit of having the robot is the diversity of the hand coordinations. You have the way that you could hold the tissue and dissect gives you a three-dimensional the range of movements. What I'm trying to say is it is spectacular when it comes to robots. The way to, for example, suture is really a joy, as opposed to not that actually it's not a joy with the laparoscopy. But for example, in sacrocolpexy, we close the peritoneum after we finish everything, so there's a lot of suturing there. With the robot, you want to get to that part of the procedure because it's really a joyful thing to do. Beside that, the quality of the visions, with the three-dimensional visions, as you mentioned, the 270 degrees or the more than the 90 degrees, I think, improve your appreciations of the space so much. And I add one more issue with it. In cases where you need to use a lot of the energy connected instruments with diathermy and other things, the fuming inside the peritoneal cavity really becomes trouble. With the robot, they have specific in-seal mechanisms or ventilations that it doesn't matter how much diathermy you're using, it clears it out very, very quickly. Now, there are similar systems to be used in the laparoscopy, but it uses a lot of the gas, and it's the opposite of being cost effective. Now, you can argue robot is not cost effective, but these are the negatives and positives of the two systems.
Yeah, I fully agree, especially that the fact that you control your own camera and the quality of vision from a short distance.
Yeah. Not to discredit the assistant, but you really don't need the assistants to tell you to come closer or zoom out or zoom in or anything to do with that. And that's standardized the quality of visions at all the time during the procedure.
100%, and sometimes the assistant reaches an area that he cannot help you any further. I remember last week I've been stitching an esophagus deep in the mediastinum next to the heart robotically. I don't think I can do that laparoscopically without the need to open the chest altogether. So I do agree, although sometimes the robot is overrated and it is not cost effective. I am actually, I think I am done with my questions.
Can I add one thing about the robot? Just one thing. Sorry.
Go ahead.
It has been postulated that that you don't have to be good in laparoscopy to become a robotic surgeon. I really dispute that. It's important to be a good laparoscopic surgeon before you become a robotic surgeon, because the appreciation of the space as well as the usability of the instrument is influenced by how well you are managed with the instrument otherwise. In the States, you don't have to become a robotic surgeon after done a laparoscopic procedure, and therefore I've seen a number of specialists that came to one of our workshops a couple of years ago for laparoscopic surgery, and when I asked them, what's your interest about laparoscopic, they said, we're all robotic surgeons, but the robot broke down in our hospital and we couldn't do any surgeries any after that. That's a sad fact.
I fully agree. I think to me, saying this statement is totally a marketing weapon to bring the open surgeons deep in the bush when there's no navigation.
Correct.
I really thank you. That's a very valuable short presentation. I would give perhaps another minute if there's any question. Even if the participant want to say it rather than write it, I'm more than happy. Dr. Leila, go ahead, please.
Yeah. Just want to ask about the prolapse operation. I noticed that the number of hysterectomies has dropped down dramatically with the repairs, but I at the same time the recurrence is more, especially when there is a uterine descent, and this is in my opinion it's a big problem.
Especially in uterine what?
Descent, when the uterus
That's the reasons why, because people don't know the fact that actually that you have to attend to the apex. And that's been, sorry to say, that actually it's been a problems in the operator, not the patients, because a lot of times actually people do anterior and posterior repair and say actually this is it, will be okay. But the apex constitutes 60% of the prolapse. If you don't attend to the apex, it doesn't. So the recurrence.
But a lot of doctors don't do that.
Sorry?
A lot of specialists don't do that.
True. That's why we spend 4 extra years doing only prolapse surgery.
Yeah, I noticed that. And actually the patient, after the operation, they still continue with having symptoms, and then they complain again, and then you have to refer them again to do the same operation again and again.
Not the same operation at all.
Yeah, I know, I understand. But for them, it is the same operation.
True. And that's to do with the less knowledge about the available services. And that's the difference between urogynecologists versus not urogynecologists, with all due respect to people who are in the interest group. But the reality is it's becoming more and more complicated, especially after the introductions of mesh. The complicated surgery and the outcome of surgery has been really overwhelmingly complicated. But unfortunately, there are a number of specialists that still simplify the factor and say, yeah, it's fine, you have a repair. And that's like, for example, I'll give you an example. Last year, I had a patient who had a hysterectomy because of the prolapse. After the hysterectomy, she had recurrence of the prolapse. She had another operations by one surgeon, another repair. And then she went to another surgeon, had another operation. The length of the vagina by the time that she reached me was 5 centimeters.
Oh my God.
I had to do laparoscopic sacrocolpexy for her. That was the most difficult laparoscopic sacrocolpexy I've ever done, because there's no tissue to work with. And it was literally a nightmare.
Yeah, I noticed that actually.
So that's why it's not the patient's fault. It's probably the public, maybe it's our fault. We don't advertise ourselves very well. And the same thing is I wish that people have more kind of capacity to acknowledge that this is not something that I would do, and I will give it to someone else. Like, for example, someone send me someone's with advanced stage of endometriosis and want fertility treatments. I very plainly refer them to a colleague of mine, because it's not something that I do on a regular basis.
Thank you very much, Dr. Salwan, once again.
I'll stop sharing.
Thanks. All right, I would move to the second presenter. I think I'm very glad to present Dr. Batul Nadeem, who is one of our senior as well obstetrician in gynaecology. She has more than 15 years experience in more than one state in Australia, mainly Queensland and New South Wales. She has a special interest in chronic pelvic pain and pelvic pain syndromes, particularly in the teenage and the young women, which might become a very tricky operation. On top of that, she specializes as well in pelvic ultrasound, and she used that for a variety of indications, including the above pelvic pain syndromes, vaginal bleeding disorders, and to investigate disorders of pregnancy as well. She is a mentor and a high-level researcher, and had presentations both locally and internationally, and she teaches the undergraduate and the postgraduate. Very proud to have Dr. Nadeem with us. Dr. Nadeem, please go ahead.
Thank you very much for the lovely introduction. I am very pleased to be part of this talk tonight, and I hope everybody will benefit from my talk.
Would you like to share your screen, please?
Yes. Is it there?
It's all perfectly there, yeah.
Yeah. All right. Okay. So chronic pelvic pain is a very common problem, and it is defined as intermittent or constant pain in the abdominal pelvis in at least 6 months in duration. It's not exclusively associated with menstruation or intercourse, and not associated with pregnancy. We'll have to realize that chronic pelvic pain is actually a symptom. It's not a diagnosis. And it's a very common problem that it's present to the primary care as frequent as migraine or low back pain. Actually, 1 in 6 women present with a chronic pelvic pain, and it may significantly impact on women's ability to function. If we come to the definition of pain, pain is actually the sensory and emotional experience, and it's associated with actual or potential tissue damage or described in those terms. The experience of pain will inevitably be affected by physical, psychological, and social factors. Women usually are aware of these influences, but they choose not to discuss them because they are afraid that they will be dismissed as psychological or other than non-gynecological symptoms. So with pelvic pain, there is physical component, whatever that tissue damage is coming from, but we should not forget the social or the psychological components of the pelvic pain. Today, I wanted to talk about common gynecological problem of pain. All of you do appreciate and understand that gynecology is not the only reason for pain. There must be musculoskeletal or gastrointestinal or urological causes of pain. But today I'm concentrating on the most common gynecological problem, that is dysmenorrhea, endometriosis, adenomyosis, pelvic congestion syndrome, and chronic bladder pain syndrome. Dysmenorrhea is defined as pain that begins just prior to or with the onset of menstrual flow, and it typically resolves within 12 to 72 hours. Any pain that is constant, waxes and wanes through the cycle, or occurs outside the menses is unlikely to be dysmenorrhea. Dysmenorrhea is largely divided into 2 types: primary, where there is no reason found, and it is presented in 60 to 93% in adolescents, or secondary, where there's an underlying pathology. Why does dysmenorrhea happen? What happens in primary dysmenorrhea is inside the uterus, there is an increased production of prostaglandin F2, or increase in the proportion of prostaglandin alpha F2 compared to prostaglandin E2. Inside the uterus, this results into dysrhythmic contraction, hypercontractility, which result in increased muscle tone and lead to ischemia. And it is the same reason why the patient present with gastrointestinal symptoms such as nausea, diarrhea, and vomiting. What do we do for primary dysmenorrhea? We start usually with non-pharmacological treatment. We try that for 1 to 2 cycles, including exercise, heat pack. Top that with pharmacological, which is the non-steroidal anti-inflammatory drugs, because these are the drugs which reduces the production of prostaglandin. After 1 to 2 cycles of this fails, then we go to first-line treatment, which is the oral contraceptive pills. It does not matter which oral contraceptive pills. We could use continuous, we could use the biphasic, triphasic, plus or minus non-steroidal anti-inflammatory drugs. We try this for 3 to 4 months, and if there is no response, then we'll have to start investigation for a secondary dysmenorrhea. Meanwhile, we use a second-line treatment in which it is the continuous oral contraceptive pills, and then if the woman cannot tolerate those, then progesterone only in form of 10 milligram methoxyprogesterone or 5 milligram noresterone daily. Some women may refuse to take the oral progesterone because it's associated with side effects like breast tenderness, bloatness, weight gain. So for those people, we may put Mirena intrauterine or depot injection. Now, the most common cause of secondary dysmenorrhea is anatomical abnormality, especially in the teenagers, endometriosis, or pelvic inflammatory disease. In my talk today, I wanted to emphasize the role of ultrasound as a primary diagnostic method, helping in resolving problems with chronic pelvic pain. Why I like to talk about the ultrasound? Because it's inexpensive, it's widespread and readily available. The diagnostic accuracy increases in experienced hands, and now we have what we call tertiary level ultrasounds, in which there are trained gynecologists do only gynecology ultrasounds. Using the ultrasound accurately increases the pre-laparoscopy probability of identifying relevant pathology from 58% to 73%. And because nowadays we have a high resolutions ultrasound, which enables us to see very fine details, and because there is improved imaging technique, including the 3D, 4D, and the color Doppler, so our diagnostic accuracy has increased tremendously. Now, I talked about the anatomical abnormality as a cause for secondary dysmenorrhea. So if you have a woman you've been looking after and you tried all the first line, second line, and she's not responding, then here comes the ultrasound. These are images of 3D and 4D ultrasound. And it clearly shows you in this one, this is an arcuate uterus. This is a septate uterus. This is a uterus which is having 2 cavities. And these are more forms of septate uterus. You ask me, is it only transvaginal? We have lots of adolescents whom they are sexually inactive. And the answer is we can do the same technique with a transabdominal scan. So this is a transabdominal scan where you could see there is 2 cavities, and this is the 3D constructions of that uterus. Coming to the problem of endometriosis and adenomyosis. I'm sure all of you had gone through women coming and going saying, doctor, I have endometriosis, my pain is due to endometriosis. The cardinal symptoms of dysmenorrhea, dyspareunia, and chronic pelvic pain are said to be characteristic of endometriosis or adenomyosis, but there is large proportion of women who does not present with these. Endometriosis actually affects 10% of reproductive age women, and the incidence varies with the studied population, because if we study endometriosis in infertility population, the incidence will be much higher. Now, factors associated with increased risk of endometriosis. So if you have a patient presenting with chronic pelvic pain, what makes you think that probably she has endometriosis? Nulliparity, prolonged exposure to endogenous estrogen, especially early menarche, shorter menstrual cycles, heavy menstrual bleeding, obstruction to menstrual flow that refers to the uterine anomaly, and where in this population endometriosis coexists in 40% of cases. Some studies suggest height greater than 68 inches and lower body mass index is associated with high incidence of endometriosis. Also exposure to severe physical or sexual abuse in childhood or adolescence, and a high consumption of trans-unsaturated fat. How the ultrasound can help us in this regard? There are heaps of studies done in the last 10 years on the role of ultrasound in diagnosis endometriosis. The most readily acceptable finding in an ultrasound is the presence of endometrioma, which we know as a chocolate cyst. If you send a woman to have an ultrasound and she was found to have an endometrioma, which cannot be missed really, then there is a high chance, 77 to 86% of deep endometriosis if it was unilateral. Presence of bilateral endometrioma, and that's what we call the kissing ovary, as in this case here. This is both ovaries, they are matted together. If we see this on an ultrasound, then there is a possibility, 80% chance of deep endometriosis, and we go back and we look for deep endometriosis, and I'll show you photos in a minute. Also, ultrasound can be useful in predicting the presence of superficial endometriosis. We use what we call site-specific tenderness. And that's tenderness when we elect on putting pressure on the probe while we are doing the ultrasound. Also, we can test for ovarian mobility, fixed ovaries, meaning there is more chance that there is deep endometriosis. And then the sliding SAN. The sliding SAN has a negative predictive value of 96.5%. I'll show you the video in a minute. So if there is soft markers, if there is a patient which has chronic pelvic pain and we are doing ultrasound, there is no endometriomas, but there is tenderness in some spots, the ovaries are not moving, then that means she's more likely to have superficial endometriosis, and perhaps this lady needs to be referred for a diagnostic laparoscopy. What do we mean by the sliding sign? The sliding sign is all about the mobility of the uterus. So when the probe, that's the vaginal probe, is introduced, then we put gentle pressure on the probe with pushing on the uterine fundus from the top and we're trying to see if the uterus is sliding on the bowel. I'm so sorry, this is looking too small. I don't know how to make it big, but this is a video on what is the sliding sign. So as I told you, we put pressure and look at this uterus, how is it sliding nicely on the bowel? And again, the other one is, that's the cervix. So we are looking on how is the cervix is sliding on the bowel. If this sliding sign is positive, then it's less likely in 97% of cases that the woman have endometriosis. In case of retroverted uterus, we could do just the pressure from the probe because we can't press on the uterus, but equally the same. Now, if we have a uterus which is fixed, then we go to look for deep endometriosis nodule like this one. And it is more than 80% correlation with this finding with the laparoscopic finding. You could see this nodule here is attaching the bowel to the back of the uterus, and these are thick adhesions from the endometriotic spots. This is a small endometriotic cyst. Again, this is a transvaginal scan where this is the bladder, and you could see this bulge here with a small nodule. And that's how does it look in cystoscopy, and that's how does it look in laparoscopy. What the ultrasound finding all of these nodules will help us with? As I told you, over the last 10 years, so many research has been happening in this regard, and there are so many definitions of endometriotic spots, the way they look like a nodule, or like a comet with a tail, or like rays coming. And also, this is the GA Healthcare, this is the ultrasound machine. People were produced lots of posters, so they'll educate people where to look for these nodules. This is in the area between the bladder and the uterus, behind the uterus, or in the bowel. And why we are bothered to do this? Because if you want your patient to have an optimum result from having a laparoscopic surgery, it needs to be done in the appropriate place and the appropriate hand. If you send the patient without appropriate study, she may end up in a hand of a general surgeon, with all due respect, who does not know how to deal with these endometriotic spots. And you may end up by doing a diagnostic laparoscopy only to find out that there is a complete obliteration of the pouch. There is thick anterior bowel nodules with adhesions, and then the surgeon will not be able to do anything because we need to involve colorectal surgeon. Colorectal surgeons may not be available on that day. So planning the surgery beforehand is of paramount importance to get the best result. And ultrasound is highly recommended in these cases to plan the surgery, where and what and who should do it. Another entity which can be very easily revealed by ultrasound is the adenomyosis. Adenomyotic features on ultrasound is where we have a global shaped uterus, where both the anterior wall and posterior wall are not equal in size. There is a small endometriotic cyst in the uterus. And as you can see, the line between the endometrium and the myometrium is disturbed and irregular. Another prominent feature of adenomyosis is the presence of what we call rainforest rays. And these are the rays which are coming from the presence of endometrium inside the myometrium. And these are the shadows of these rays. Now, going to another entity of chronic pelvic pain is pelvic congestion syndrome. So this is referred as the same like that varicose veins, which happens in the legs, but it's happening in the pelvis. The existence of pelvic venous congestion as a result of chronic pelvic pain is largely controversial. A recent systematic review of diagnosis and management of this condition found no valid diagnostic test. But in practice, ovarian suppression was effective in treating pelvic pain symptoms in these women, and both progestins and gonadotropin-releasing hormone agonists were used, and the GnRH were found more superior than the progesterone. This condition has a strict definition by ultrasound because, as you are aware, pelvic vein dilatation is very common, especially in the multiparous. So there is a strict feature on how to define the pelvic congestion syndrome, namely the diameter of the vein should be greater than 4, and then there will be communicating veins and the blood flow. And it's interesting to know that 50% of women with pelvic congestion syndrome have polycystic ovaries, or at least they have cysts in their ovaries. Now, this is how does it look on the gray scale. And when we put the blood, the color Doppler, then that's how they look. And we should measure the blood flow to diagnose or name it as a pelvic congestion syndrome. Another gynecological entity, which is the pelvic inflammatory disease. As you are aware, pelvic inflammatory disease could present in so many presentations, could present as an acute pain, could be subclinical. We find it while we are investigating infertility and we find blocked tubes, and then we ask the woman and there is a history of PID, or could be chronic, which looks like adhesions or tubo-ovarian abscess. So how does it look in the ultrasound? This is the ovary, this is pelvic adhesions, as you can see. This is the tubo-ovarian mass or abscess. That's the right tube, which is dilated, and look at these adhesions to the uterus. And that's what we see at the laparoscopy. So these adhesions are not because of endometriosis, these are because of PID. Another common entity, and Dr. Salwan was just mentioning it in his lecture, is the interstitial cystitis. That's the old name. Now we call it bladder pain syndrome. The bladder pain syndrome is a diagnosis that applies to patients with a chronic bladder pain in the absence of other explanatory etiologies. It's very common, and I see it a lot in my rooms where people come pointing out to suprapubic pain. And you do all investigation, and everything comes normal, and you don't know what's going on. So it results from neurological upregulation of pain sensation and central sensitization and increased activation of bladder sensory neurons during normal bladder filling. So it's characteristically that the pain is perceived to be located in the bladder and worsen with the bladder filling or is relieved by urination. So in patients with pelvic pain that is not impacted at all by bladder filling or emptying, then this is not the diagnosis of bladder pain syndrome. So with the diagnosis, traditionally it is diagnosed by cystoscopy and finding the Hanner lesions, which I'll show you in a minute, but we could use the ultrasound, transvaginal ultrasound, to look for the volume of the residual urine, and also to look for urethral diverticuli. So this is the Hanner lesions or the Hanner ulcers, which we see by cystoscopy. When we do an ultrasound, this is just schematic presentation, make it look easier. So this is the urethra, this is the vagina, this is the rectum. That's how they look on transvaginal scan. And you could see here this cystic dilatation going this way, that is a urethral diverticulum. How do we treat this condition of chronic bladder pain? Dietary modification has been proven to have some beneficial effects, so avoidance of caffeine, alcohol, and acidic food. Stress management by regular exercise, analgesia, and some data, but is not very much rigorous, on the benefit of acupuncture. As a management, a thorough medical history should be taken and physical examination performed. Patient will need a bladder diary to confirm the symptoms. Again, food diary is important, and we should test the urine for presence of infection, and particularly urinary uroplasma and chlamydia. And then also, if there is a suspicion of malignancy, then urinary testing for cytology. Oral amitriptyline or cimetidine may be considered when first-line conservative treatment has failed. Cimetidine is off-label, but is found to be helpful in these patients. Now, I will talk in general on management of chronic pelvic pain. So with patients with chronic pelvic pain, it's of paramount importance that we give adequate time for the initial assessment of women. We should give them the time to tell their story. Women like to be heard and like to be listened to and believe that their symptoms are genuine. Many women, they come to see you just because they want explanation of the pain. not necessarily wanting you to give them treatment of the pain. They just want you to tell them why she's in pain. Usually they developed a theory for this pain. Usually they are thinking of what is the original pain. And it's very important that we listen to them and discuss these ideas. You can't believe, no matter how many medication you give or how much brilliant surgeries you do, if this woman, you don't explain the component of the pain, origin of the pain, she will not be satisfied. She'll be coming and going again, pain and pain. We'll have to explain and make the woman understand that it's a multifactorial nature and there is no single cause. It's a combination of so many influence, including musculoskeletal, psychological, social. The aim of the management should be to develop partnership between the clinician and the woman to plan a management program. Now, diagnostic laparoscopy in the past was considered the gold standard in the diagnosis of chronic pelvic pain. Nowadays, we think of diagnostic laparoscopy as a second-line investigation if everything else had failed. 30 to 50% may be negative, and also it is associated with risk. So there is a risk of death, 1 in 10,000, risk of injury to bladder, bowel, blood vessels, and maybe when this complication happen, you may need a laparotomy. So you wouldn't like to expose your patient from the word go to such risk. Therefore, proper assessment for the patient and knowing who's the one who will need the laparoscopy from those who doesn't is very important in your management plan. So women with cyclical pain should be offered therapeutic trial using hormone treatment in a period of 3 to 6 months before sending them for a diagnostic laparoscopy. While they are waiting or while we are thinking of doing a laparoscopy, they should be given appropriate analgesia. If the conservative oral treatment is unsuccessful, other therapies should be added, but it should be individualized and tailored to each patient need. There is no one treatment suit everybody. And we'll have always to remember multidisciplinary approach. So talk to your colleagues, talk to your friends about that particular patient and know how to tackle her problems with involvement psychologist, maybe a social worker, maybe occupational therapist. If the pain is not adequately controlled, after you've done everything, then consideration should be referral to a specialized pelvic pain clinic, and there are several of them, I'm sure, in every state. So the take-home message from this talk is pelvic pain is very common. It has a complex nature and it's multifactorial. Allow enough time for counseling and explore women view. Management, as we said, is tailored individually, and we should involve multidisciplinary teams. We start with simple analgesia and oral contraceptive pill. Use the ultrasound as first line of investigation. You gain lots of information from doing the ultrasound, and leave the diagnostic laparoscopy if the primary intervention fails. That's all what I want to tell you. Thank you very much. Can't hear you, Dr. Mohanad.
Yeah, can you all hear me? Sorry for that. Yeah. Thank you very much, Dr. Abatul. Very nice summary. For the sake of time, it's 13 minutes past 9. We would move direct to Dr. Media Elias, perhaps to say a few minutes right in the end to answer some questions. Dr. Elias is once again an established gynecologist obstetrician in Victoria. It looks like Victoria tonight are winning against New South Wales. She actually practiced in different and multiple areas, inclusive but not limited to North Park Private Hospital, Western Specialist Centers, and others. Her areas of interest as a subspecialty, in addition to her general gynecologic duties, are especially the pre-pregnancy planning in terms of preconception, early pregnancy care, high-risk pregnancies, And not only that, in gynecology as well. She is interested in adolescent gynecology, menstrual disorders, polycystic ovarian syndromes. She has advanced laparoscopic and open skills due to her multiple years of practice. We're very glad to hear from Dr. Elias. Please proceed ahead. Tell us about an update on contraception.
Thank you very much. I'm just trying to share my screen.
I can see your screen.
Can you see? I'm just trying to make the slides sort of on a slideshow. Here we go. Yeah, great. So thank you so much for the great introduction, and thank you to Ayama and mainly Dr. Muhannad Al-Jaber and Dr. Ahmed Al-Rubai'i for the great presentations and putting all of these webinars together. Before I start, I would just like to welcome Pooja Sood, who's the representative of Baya. She's actually sponsored my talk. So thank you so much to Pooja. She will kindly share her details as well. So if anybody would like to contact her to get some more information or brochures or samples, she will be very happy to do so. So without further delay, I will just take you through the content of the talk tonight. Will be about contraceptive use in Australia in general, and then we're introducing Kyleena and its suitability, and its efficacy, bleeding profile, and tolerability. We know from the survey of the second Australian study of health and relationship that about 66% of women in Australia uses a method of contraception. And out of those, 1/3 use oral contraceptive pills, and the rest different methods. But out of those, about 6 to 10% use a long-acting intrauterine contraceptive method. And looking at those groups, dividing it by age, it seems like, yes, younger women, age 16 to 29 years of age, prefer using the oral contraceptive pills. But older women from 30 to 49 years of age prefer using longer acting intrauterine devices. And looking at adherence of women to oral contraceptive pills shows that about 39% of those women have forgotten to take their oral contraceptive pills at least once in the last month. And 39% admitted into not taking at the same time every day. And we're looking further into those groups that globally, the most common reason was because they have busy schedule and not keeping their pills at the same place. And therefore that can lead to unintended or unplanned pregnancies. And about 1 in 4 women have at least 1 unintended pregnancies. And of those, 64% were oral contraceptive pills users. So they have forgotten the pills or not taking it appropriately, but 6% were using longer acting reversible contraception device. And the rate of abortion in Australia is about 1 in 6 women who have had unplanned pregnancy reported that 1 in 3 of those will end up seeking an abortion. That will take us to introduction of the new long-acting intrauterine device, which is the Kyleena. I'm sure many of you have heard about it. And Kyleena, it is the new intrauterine delivery system that has 19.5 milligram levonorgestrel in the whole of the 5 years period time. And it has a small T body, which is a 28 by 30 millimeters, and a narrow intrauterine insertion tube of 3.8 millimeters. And if we compare that to the size of the T body and insertion tube of the Marina IUD that we have used for many years, we can see that the difference in the size of the Kyleena has 3.8 millimeters of width compared to the Mirena of 4.4 millimeters. And that will make the insertion easier, being smaller. And also the Kyleena has that silver ring at the end of the insertion arm, which make it a bit easier to find it on the ultrasound scan. And the third difference is the thread. So the Mirena has a brown thread when we do the examination and find it on the speculum examination to check the positioning. But the Kyleena has the blue removal thread. So that makes it easier to distinguish the difference. The mechanism of action is similar to the Mirena IUD. So after insertion in the uterine cavity, the endometrium becomes relatively insensitive to the circulating estradiol, and that produces a strong anti-proliferative effect. And also the effect of the levonorgestrel make the cervical mucus thicken, so it prevents the passage of the sperm through the cervical canal, and the changes in the local melia of the uterus and the fallopian tube will affect or inhibit the sperm mobility and function, and therefore fertilization will be prevented. And we know also the same thing with the Mirena IUD, that there are evidence that ovulation still happen in majority of patients who are using it. So Kyleena is effective for 5 years as a contraception device. And looking at the unadjusted Pearl Index at 3 years and 5 years, it looks like the number of pregnancies or failed pregnancies with the use, it still remain very small. So the cumulative failure rate was 1.4% at 5 years. So it is overall very effective in prevention of pregnancies. The common question that the patient asks is return of natural level of fertility after discontinuation. So we can reassure our patients that the fertility will be returned after discontinuation of the use of Kyleena IUD, given that they don't have any other reasons. So in one of the studies of 163 women found that after they discontinued using the Kyleena, 37% of them conceived within the first 3 months, and 71% conceived within the first 12 months. It is suitable for both nulliparous and parous women. And looking at the ease of placement, we will all know that the ease of placement will be easier in a parous woman, especially if they've had vaginal delivery, compared to nulliparous or women who have had only cesarean section for their delivery, and that is because of the narrow cervical canal. And asking patients about the pain and their pain score on placement was really similar. So parous women and women who have had vaginal delivery found it much easier and less painful at the time of insertion compared to nullipara women or women who have had cesarean section, but overall it was very tolerable. And in this study, there was a comparison between the ease of pain of placement, where the operator was asked, and then the patient was asked about if they felt pain during insertion or not, and found that was very well tolerated. And most patients, found that it was less painful. So being smaller and narrower arm, that the Kyleena was much less painful at the time of insertion. The effect of Kyleena on the bleeding profile, having low dose of the levonorgestrel, it's also very effective in reducing the heavy periods. So in over 5 years period, it found that the rate of the heavy periods and bleeding was reduced considerably over time. And in this graph, we look at 90-day interval from the time of insertion ongoing 3 months post-insertion. We can see that the number of days of bleeding has reduced from 17 days to nearly 3 days from the first day of insertion. as well as the mean number of the bleeding and spotting in the 3 months has reduced significantly. So that I think could be one of the main reassuring factor during consultation, that the first 1 to 3 months, yes, can be a bit problematic, but with reassurance that this will get easier and it will sort itself. And compared to other hormonal intrauterine devices like the Mirena, or compared to the progesterone-only pills or the combined oral contraceptive pills, the median percentage of bleeding or spotting days were consistent, but was much less in women who have switched from a hormonal contraception like the pills, then they've used the Kyleena, compared to women who have had, for example, used condoms before. Therefore, their period took a little bit longer to become lighter after the use of Kyleena. So the main implications for counseling, we need, I think, to now increase our awareness, because Kyleena is available on the market, and we need to educate the patients about its use. We can comfortably and confidently say that the bleeding pattern in the first 3 months post-placement will depend on what method of contraception they've used prior. And if it was non-hormonal, it might take 1 to 3 months for it to become lighter. And most women will experience progressive decline in the number of bleeding and spotting. But it is very useful in that matter, especially in women who have had heavy periods. And it's not really, I will probably say, it's not promoted as this method will actually make them have amenorrhea, because this is not what the Kyleena IUD will do. It will reduce the bleeding rate, but it will not make them, most of them, it will not have amenorrhea. This is what they're looking for. Looking at the safety profile of Kyleena, so the 3 main areas looked at was the complete or partial expulsion of the IUD. And I mean, this is a talk on its own, whether partial expulsion is of any clinical significance. Sometimes you can see on the ultrasound scan reported as that it is lower in the fundus compared to higher in the uterine cavity. But if the patient is totally asymptomatic, it's probably not of significance. The other area that was looked at was uterine perforation. So in that group of 1,400 women, there were 3 uterine perforations. They were not actually true perforation. They were mainly the arm of the IUD was embedded within the uterine wall, and that was removed in all of the 3 cases vaginally successfully without needing for any further intervention. Rate of pelvic inflammatory disease was also very low at 0.6%, and ectopic pregnancy of 0.6%. The big question of, will I put on weight, doctor? This is a hormonal intrauterine device. And this is what I tell my patient, even with the use of Mirena IUD, very rarely that it can cause a major weight gain. So looking at the phase 3 trial, an extension, the mean weight gain was 1 to nearly 3 kilos in the 3 to 5 years interval. Keeping in mind adjusting to all other factors. And the main factors or reasons for the woman to discontinue the use of the Kyleena IUD was the ongoing vaginal hemorrhage, or the expulsion, or the ongoing pelvic pain, but overall was very small rate. Contraindication of Kyleena IUD, it is very similar to the Mirena IUD insertion. So some of these factors is well known. So significant distortion of the uterine cavity, as the Batul said, if there is like 2 uteri or a big septum, then you know it's not going to be working well in that uterine cavity. And it is not suitable for initiation in patients who have active pelvic inflammatory disease or undiagnosed vaginal bleeding. or immediate post-septic abortion, or if the woman has any active breast cancer or active liver diseases. So as an overall view, if we compare the Kyleena intrauterine device to the current Mirena intrauterine device, the indication is very similar. They're both contraception and that can last for 5 years. And they have a very high efficacy and low failure rate. They both have levonorgestrel, but very small dose in the Kyleena of 19.5 compared to the Mirena of 52 milligrams, and the average daily rate of release of the levonorgestrel will be 12.6 in the Kyleena compared to 20 micrograms per 24 hours in the Mirena IUD. The change in the bleeding, menstrual bleeding pattern, the rate of amenorrhea, it is slightly more in the Mirena IUD because of the higher dose of the hormone. The T-frame size is narrower, which is one of the features and probably the reason that will make us use the Kyleena in relation to the low hormone level. And the color of the thread is blue in the Kyleena compared to brown in the Mirena. And it has that silvering at the end of it, easier recognition in ultrasound. So as an overall, it is effective, the Kyleena IUD for 5 years. For conception, it is suitable for both parous and nulliparous women, and it has shorter and less frequent bleeding pattern over time of use, and it's very well tolerated over 5 years period. Thank you very much, and very happy to receive any questions.
Thank you very much, Dr. Media. Very good presentation. I would open the floor to any questions. There is actually a question or comment from Dr. Zina Jawad saying that women who use hormonal contraception then insert Kyleena will have more or less bleeding or spotting compared to women who use non-hormonal contraception. Can you please explain? Dr. Media, did you get the question?
Sorry, Dr. Mohamed.
Yeah, I'll say it again. So women who use hormonal contraception then insert Kyleena will have more bleeding or spotting compared to women who use non-hormonal contraception. Can you please explain or give a comment on that?
Sure. So if the question is switching to the Kyleena or Mirena,
yeah.
If the woman is currently using hormonal contraception like the pills, and then they are now switching to either Mirena or Kyleena IUD, I don't think they will have they will have less bleeding after the IUD insertion. But what I will suggest is continuing the use of the current pack of the oral contraceptive pills. So if they are halfway through their pack and you insert the IUD, whether it's Mirena or Kyleena, I normally ask them to continue that pack and then discontinue when they reach the sugar pills at the end. And generally speaking, if they have been on the oral contraceptive pills, they will have less bleeding pattern or less spotting or annoying bleeding after the IUD, Mirena or Kyleena insertion.
Sure. Thank you very much. Okay, so it's very clear to Dr. Zina. So I cannot see any more questions. Any questions?
I have a question. Dr. Mohamed.
Yes, go ahead, please. I can hear you. Go ahead, please.
Yeah. First of all, I would like to thank our colleagues, Dr. Selwan and Dr. Batul and Dr. Media for the excellent presentation. I have a question for both Dr. Selwan and Dr. Batul about pelvic floor muscle. In gastro, we have an entity called obstructed defecation, which is related to 2 factors. One of them is the sphincter dysfunction, and the other one is pelvic floor dysfunction or weakness. This is the manifestation on the side of the constipation. But on the side of gynae, what's the manifestation of pelvic floor muscle, and is there any measure of it? Because for us, this is a measure of motility. So we do it by nuclear imaging, and through colonic transit study, we differentiate between the causes of constipation. So it is not a real objective measurement of the weakness. Is there any measurement to this weakness, first of all? And secondly, what's the gynae features of this weakness?
Do you want me to answer first or you first, Salwan?
You go first.
I'll go first. Okay. In terms of pelvic muscle, there is what we call a transperineal ultrasound, which we do for women who have vaginal prolapse or incontinence, or those women who had trauma during birth, 3rd and 4th degree tears. With the transperineal ultrasound, we study the relationship between the pelvic floor structures, namely the neck of the bladder, the vagina, the cervix, and the bowel. And there are certain measurements online which we do to appreciate how much is the descent with Valsalva or without Valsalva maneuver. But this will give us an idea on the type and weaknesses of the pelvic floor. Plus, we could do a 3D, 4D reconstructions of the external anal sphincter and the sphincter complex to see if there is any defects from previous traumas, childbirth, and so forth. Whether this study in ultrasound will help you to decide the bowel dysfunction, I'm not quite sure, because this looks at the muscles and the relationship between the structures. I guess it's a combination of so many things. Like from your end, you are studying the motility. From my end, I study the muscles and structural relationship and see if there's pathology. Maybe there is a uterine fibroid, or especially posterior fibroids, retroverted uterus with adenomyosis, probably endometriotic spots on the rectovaginal septum could add to the problem. But whether you could use it as a separate modality to diagnose the dysfunction, I'm not quite sure of that.
The relationship between pelvic organ prolapse, specifically the rectocele and the obstructive defecation, is very prominent. And while Batul mentioned about the perineal ultrasounds, and we do, like, for example, indural ultrasounds and manometry for different reasons, for the integrity and the functions of the external and the internal anal sphincter. But just in my mind, it's very simple relations to the obstructive defecations when there is a rectocele. With the rectocele, the pelvic floor support system, which is predominantly the extension of the fascia, and that's have been disputed before and then refuted by the cadaver studies. The sacrum is connected to the perineal body, and the connections between the two is via the perineal body, which is the confabulations of the perineal muscles, and then to the rectovaginal fascia, to the uterosacral ligaments complex, to the cardinal, and to the broad ligaments, and in turns all the way to the sacrum. The loss of integrity, which is predominantly related to childbirth, namely posterior presentation, rotational forceps, whatever causes that disruption, causes lack of the trampoline-like effect between the vagina and the bowel. And that permits the later part of the bowel to protrude through the vagina as a weakness point. This can end up causing the number of factors: the poor evacuation and less satisfactory evacuation, and becomes like a vicious cycle, the patients, if they have any predisposing factors for their constipations, these trainings will increase the pressure on the lower part and inadvertently or advertently will go through the weaker point, which is through the vagina. I'll give an example about it. Actually, there are a number of spatulas are sold on the internet and the market that women can use to push on the vaginal wall in order to help evacuate the bowel. I don't advocate for it, of course, because this is not a solution. It's just actually reductions in symptomatology. So while there is, in my practice, I don't use any imaging modality to recognize the difference between the two. I do rely heavily on the physical examinations to pick up the relationship between the two, and I attribute the success of or resolutions of the evacuations after posterior vaginal wall repair between 30 to 40%, and the rest of it to do with the bowel. Does that answer the question?
Excellent. Thanks for that. Thanks. Dr. Mohammed, you are muted. We can't hear you.
So once again, I mute myself so no noise from my side here. I thank everyone for the great presentations, and I thank the participants as well for their valuable time to attend our webinar. And if there is no comments or questions, perhaps I may conclude the session.
Can I just have one add that the next webinar will be in psychiatry, and that will be again 3 presenters from Sydney and from Perth. That most likely will be on the 17th, just to add to this one.
On the 17th of December. Thank you, Dr. Ahmed. All right, well, once again, I thank the presenter for the valuable time and information. I particularly learned a lot, and hopefully we see you all and more next month, 17th of December, to learn about a few things in psychiatry. Thank you very much to everyone, and have a very good night. Thank you very much.
Thank you.
كثير انبسطنا فيكم يا حلوين.
شكرا، الله يخليك. شكرا.
موفقين إن شاء الله.
شكرا أجمعين. شكرا.